Welcome to the first virtual Crossroads of Ideas. My name is Laura Heisler, the Director of Programming for the Wisconsin Alumni Research Foundation, WARF, and also an affiliate of the Morgridge Institute for Research and the Wisconsin Institute for Discovery. We three organizations share the Discovery Building on the UW-Madison campus, which is the home of this series in normal times. Needless to say, these are not normal times. We canceled our regularly scheduled topics for this semester and are instead partnering with UW Communications to bring you a three-part mini-series focused on how UW-Madison is helping to address the coronavirus pandemic. This first session focuses on what the campus is doing in the immediate onset phase of the pandemic. The second session is scheduled for April 30th at 5 p.m. and will focus on settling in and managing the extended consequences of the crisis. Stay tuned for a final installment in the coming weeks on where we go from here as we navigate the next stage. I have a few housekeeping notes for today's session. We'll be meeting our moderator in just a moment, and then we'll hear from each of our 5 panelists. Towards the final portion of the hour, we'll be addressing your questions. You can use the chat box on the lower right-hand side of the screen to ask your questions, and our moderator will select several of these for our panel. With that, I'm delighted to turn things over to the Interim Director of Science Communications for UW-Madison, Kelly Tyrrell, to moderate the session. Kelly?
Hi, and thank you, Laura. Thanks to all of you for joining us from wherever you are for the start of this three-part series. This is the first time that we've done something like this, so we ask you to bear with us as we're doing our best to share with you the perspectives of these 5 UW-Madison experts, all of whom have played critical roles since the start of the COVID-19 pandemic. As someone who once contemplated going to medical school and ultimately earned a graduate degree in molecular biology, I have long been interested in infectious disease. When this novel coronavirus showed up in China in late December and early January, I, like many of you, turned my attention to it. In late January, I had the privilege of hearing on a panel discussion some of the earliest information about the virus that causes COVID-19 from 2 of the very people taking part in this event tonight. One of them was Kristen Bernard, a professor in the School of Veterinary Medicine who studies diseases that affect animals and people. Dr. Bernard studied earlier outbreaks of the coronaviruses that cause SARS and MERS and will help us understand the biology of SARS-CoV-2. So with that, I will turn things over to Kristen.
Thank you so much for that really nice introduction, Kelly, and thank you for the invitation, Dr. Heisler. And it's really an honor to be here today on this first virtual. It's a little odd, I will admit, but we'll give it our best. And what I just want to do in my few minutes here is to give you a little bit of background on coronaviruses and how they infect animals and people. So viruses in general are always divided into families, and the coronavirus is its own family. And the viruses are made up of a genome, a very large RNA genome of about 36,000 nucleotides. And the genome is surrounded, as you can see on this slide here, by a lipid bilayer with spike proteins. And those spike proteins are what attach to the cell and also what gives it the name coronavirus, because it looks like a crown on this electron micrograph. And I think you can see that. The coronavirus family has a lot of different members, over 30 different members, and the viruses are known to cause very mild colds in people. So there are some coronaviruses that are responsible for about 60% of human colds. Also, a lot of viruses that can infect our domestic animals, including cats, dogs, swine, cattle, horses, and birds. And in particular, it's usually mild disease in these animals, but in cats, swine, and poultry, we have very severe disease and are a great concern to veterinarians. So how did these viruses actually emerge? How did this novel coronavirus, or now we call it COVID-19, emerge? Well, there have been 3 different coronaviruses that have jumped from animals into people. One of them was the SARS coronavirus type 1 that Kelly referred to. And this stands for, the SARS stands for Severe Acute Respiratory Syndrome Coronavirus. And then also there's MERS, which is Middle Eastern Respiratory Syndrome Coronavirus. And now our new COVID-19, which actually has the name of SARS coronavirus 2. And SARS coronavirus 1 and 2 are the most closely related of these ones that we're going to be talking about today. All 3 of the viruses cause a similar severe respiratory syndrome in people. And let's just go through how they emerged, and at least how we think they emerged. In 2002 and 2003, SARS coronavirus 1 emerged. And its ancient relative most likely was from bats. So it was a bat SARS-like coronavirus, and some animal in between the bats and the palm civets is where the virus probably adapted to the different animal hosts. People then obtained this virus by contacting palm civet cats in wild animal markets. And this happened in southern China in 2002. We then saw human-to-human transmission with spread throughout the world, including up to 27 countries. And there were about 8,000 cases of this SARS type 1. But by the middle of 2003, we were able to stop the transmission of this virus, and it became extinct in humans, and we never saw the virus again. The next virus that jumped into people was MERS. And that MERS coronavirus, again, bats appear to be the ancient relative. It probably then adapted in other animals and got into camels. And now camels are the ones that spread it to humans. And we continue, since 2012, continue to see cases in people, and there is some low level of person-to-person transmission of this virus. But at this point, since 2012, we've only seen 2,500 cases, and it really needs close contact, including healthcare workers and family members, for the virus to be spread. Now, of course, we all know in December 2019, we had our 3rd jump of coronaviruses. And like our SARS coronavirus 1, our SARS coronavirus 2 has an ancient bat virus as its most distant relative. And we don't know at this point what animals it then went into next to be adapted, but we do believe that is the case, and that it then adapted to some other wild animal before people actually were transmitted. And you can go ahead and go to the next slide. And this people then became infected, and most likely in a wild animal market in Wuhan. And in that case, we of course now see tremendous human-to-human transmission. In contrast to that SARS coronavirus 1, where we saw 8,000 cases, at this point in time, the WHO reports over 1.8 million cases and over 117,000 deaths. So of course, this transmission from animals to people has much greater impact and became a pandemic. We still have a lot to learn about COVID-19 or SARS coronavirus 2, but I'd like to close with these thoughts. In addition to the healthcare workers on the front line, UW-Madison researchers have really stepped up. They've applied all their knowledge. They never had worked on coronaviruses before, but we have people that are trying to improve diagnostic tests, studying how the virus causes disease, epidemiology, how it's transmitted and how we can stop that transmission, how we can make new PPE, and develop new vaccines and antivirals. And I just want to say that everyone on campus is pulling together, the staff from everywhere, the researchers, people in biosafety and facilities, and it's really a tremendous effort. And I'm really proud that UW-Madison is making this happen.
Thank you so much, Kristen. You're absolutely right. People have really pulled together, and it's been pretty incredible to see. As a reminder, submit your questions for the post-presentation discussion. You can do that throughout the presentation. For now, we'll hear from Ajay Sethi, a professor of population health at the UW School of Medicine and Public Health, who studies epidemiology and infectious disease. AJ, you're up.
Yeah, thank you. Thank you, Kelly. And thank you, Dr. Heisler, for inviting me. I'm honored to be with my colleagues on this panel. So my name is Ajay Sethi. I'm an associate professor in population health sciences at the UW School of Medicine and Public Health. I'm one of many people on campus, faculty, staff, students with wide-ranging skills and expertise responding to the COVID-19 crisis. Over the last month, I've learned a great deal from them, and I'm grateful for that. My training is actually in infectious disease epidemiology. Most of my research has focused on HIV and on healthcare-associated infections. I've never studied coronaviruses, but like so many others on campus, I certainly felt the urgency and call to service to help in the response to the COVID-19 crisis, really in any way I could. About a month ago, I, along with a colleague at the university, were invited by UW Health to join a team of clinicians and data scientists to model various aspects of the COVID-19 crisis in hopes to predict its impact on the health system and on the community. Our team reports forecasts to UW Health Incident Command, and we help them estimate how many beds, ICU rooms, and ventilators will be needed to care for patients with COVID-19. Our team approaches modeling the same way a lot of modelers do. We look for and use the most relevant and recent known information about three things: how COVID-19 spreads in communities, who gets the infection, and how severely they are affected. We rely on information from the CDC, from China, from Italy, and other places where COVID-19, that epidemic, is further along. And so we use local data whenever possible. We don't have a handle on how many people get COVID-19 infection, and I'll talk more about that shortly. We then applied this external information to daily case counts of confirmed cases in South Central Wisconsin, along with the characteristics of residents in the region, to forecast the epidemic for the weeks and months ahead. We try to find a balance between respecting the uncertainty inherent in all forecasting methods with the need to provide information that allow decision makers to do their job. But there are two big unknowns that challenge our efforts. And first, because criteria for COVID-19 testing have been restrictive and focused on those who have symptoms, it has functioned more as a diagnostic test and not as a screening test. So as a result, we really don't know how many people in the community actually have COVID-19 or have had it in the past. And as you know, testing in the US really was slow at the start. Now things have improved, but we are still pretty behind and trying to catch up. Testing criteria really do need to be broadened, and testing itself, particularly with rapid tests, need to expand much further, and I'll tell you why in a moment. Physical distancing is working in Dane County and in South Central Wisconsin. The daily counts of COVID cases are on the decline, and we should all be very proud of this tremendous achievement because lives were saved. But this is also the second big unknown. Will we be able to sustain physical distancing? The curve is flattening, but we need to get to the point where there is no curve at all. And Wisconsin's safer at home order is due to expire in 10 days on April 24th. If it is not extended or an alternative equally effective solution is not put in place, we are at risk for a second wave of COVID-19. And this exact same thing is happening in China as a result of relaxation of what were effective measures to slow the virus's spread. Many of us are, missing watching favorite sports teams right now, and I'm not always a fan of war or sports analogies, but I think the latter works here. Imagine the outcome of that game when your team came out flat after halftime and didn't play the full 4 quarters. Now imagine the outcome when your team never let up. And which outcome did you prefer? We are in a mitigation phase, and we must get back to containment. We need to greatly expand testing once and for all and carry out aggressive contact tracing to finally get ahead of this epidemic. And to do that for the full 4 quarters and over time if necessary. Now at the university, I'm also faculty director of the Master of Public Health program. And I think we all can agree, UW students are our lifeblood. They are among the most important vehicles for disseminating high quality information throughout the community, and they're really skilled at it too. With that in mind, we organized a webinar called COVID-19 Being an Effective Opinion Leader, which you can find on our MPH program's YouTube channel. There are 30 minutes of expert panel presentations from campus leadership, the state lab, the School of Medicine and Public Health, and risk communication. And then this is followed by 30 minutes of Q&A, and I encourage you to watch that webinar. I will close by saying that many, if not all of you, have the ears of your family, your friends, and your communities. And it is important we continue to recognize that we're all in this together and we have the ability to stop the spread of COVID-19. And thank you.
Thank you so much, Ajay. Malia Jones is our next presenter. Dr. Jones is an epidemiologist in the UW-Madison Applied Population Laboratory. She studies the social factors that influence health. Please take it from here, Malia.
Thank you. Thanks for inviting me. I'm delighted to be here today, live from my home in Madison, Wisconsin, where it is sunny and snowing. And I echo Kristen and Ajay in saying it's my honor to be here. I'm a hybrid social infectious disease epidemiologist, and my training is in public health and demography. And like almost everybody else here today, I don't typically study coronaviruses. I normally study herd immunity, and especially for vaccine preventable infectious diseases like measles, HPV, and influenza. In particular, I study spatial and temporal dimensions of herd immunity and how people who are not vaccinated cluster in different settings like schools and neighborhoods. And I do this with statistical, spatial, and simulation modeling approaches. I'm also actively engaged in a program of translational research with the goal of communicating directly to the public about demographic issues facing Wisconsin in partnership with a media outlet called WisContext. And so as this pandemic began to unfold here in Wisconsin, I found myself with a unique intersection of skills. I see it as my responsibility as a scientist and also as a Wisconsinite to spend my time making scientific information approachable and useful to as broad an audience as possible. Most people don't have the scientific training you'd need to make use of, for example, the sources of uncertainty in a model, like Ajay just mentioned. But here we are in a position where we need all people to participate in the solution and take the safer at home orders seriously and limit their contacts. So as I saw this all begin to unfold, I found myself with this unique set of skills to help interpret what's happening, even though I don't normally study coronaviruses or pandemic situations. And so my contributions to this pandemic response in Wisconsin and nationally had sort of an accidental starting point. It started with an email. In the first week of March, I wrote an email to my friends and family about the pandemic from my perspective as an epidemiologist. And that message quickly went viral on Facebook and was ultimately featured as an editorial in the Milwaukee Journal Sentinel and then in USA Today National. Many of you may have seen it there. This fame was both unexpected and stressful for me, but I saw it as an opportunity to do something that is very rare for a social scientist, which is to save lives. I took to doing regular appearances with the media and the general public to explain why physical distancing matters and how urgent it really was. And since then, I've done dozens of interviews in local and national media, been quoted in the New York Times, and appeared on Dr. Phil even. So since then, I've been continuing my efforts to do direct-to-public scientific communications on the pandemic. Along with 10 other scientists across a range of disciplines, I started a public-facing social media platform called Dear Pandemic. Our mission is to curate and post factual, actionable information about the pandemic for the general public. On Dear Pandemic, we are explaining what's happening and filtering and curating information sources to boost the role of the scientific voice in the public dialogue on the pandemic. On Facebook, we have over 6,000 followers, and we get thousands or tens of thousands of impressions per day on each post. And we also have a coordinated presence on Instagram and Twitter. So looking ahead in terms of my research program, I'm working on research questions about how to achieve outbreak management and recovery in the medium and long term. A lot of people are asking, when can we go back to normal? And I think that normal is a difficult word here. Ultimately, we need to achieve herd immunity in order to have ongoing control of COVID-19 and return society to something like what it was before the pandemic hit. But there are a number of complications to that ultimate solution. The way to achieve herd immunity safely is through a vaccine. And although vaccine development is in progress already, how long it will take is not known. I can tell you that it will be a while, and I would say at least 18 months and maybe longer. So herd immunity is the long-range solution. And in the meantime, in the medium term, we need to understand a more conservative approach to physical distancing that allows some elements of society and the economy to begin to recover. So I'm currently working on models to help understand what's necessary given what we know about the disease dynamics and the contact networks of the population. What's clear now is that relaxing physical distancing safely relies on the ability to test widely, quickly, and accurately, including for asymptomatic people. We also need there to be relatively few circulating cases so that we can do contact tracing and follow up all those contacts of someone who becomes ill. And for now, until we have those elements and others in place, we really need to continue to engage in physical distancing, or we face a very swift return to where we were a month ago in terms of a second epidemic wave. So in closing, I'll say that what I've seen over the last month has been challenging on many fronts, both professionally and personally, of course. I think in many ways, it's very hopeful. I have never seen the scientific community respond so quickly to any crisis, and we learn new things about COVID-19 every single day. And I have a lot of hope that the ingenuity of the scientific community will help us to manage the crisis.
Thank you so much, Malia. You've been a really good example of the ways in which UW-Madison experts have really stepped up and taken their expertise to confronting this pandemic. Please remember, you can submit your questions for our discussion that we'll deal with after the presentation. So for now, we'll hear from Brian Yandell. Brian is the interim director of the American Family Insurance Data Science Institute at UW-Madison and head of a new effort to use data science to understand and respond to the COVID-19 pandemic. Brian?
Thank you. I got involved in this. Well, I'll say a little bit about my background. I'm a professor in statistics, and I've been working for quite some time with biologists on data science type problems. In the last 10 years, became aware of the term data science and realizing there are a lot of other needs, data science needs across the campus, across society, and started talking too much, and ultimately was asked to be interim director for this American Family Insurance funded Data Science Institute. If I could have the first slide. So we're about 3 weeks ago, about 4 weeks ago, my yoga teacher told me sent me an article which got me scared, frankly, about what's going on. And I started contacting other data scientists, and four of us met on a Thursday and Friday, and we set up a conference meeting. By Monday, we had about 40 people, and that's grown to over 100 people in this, what we're calling the COVID-19 research group, DSI COVID-19 research group. We have a website where you can find a lot of information. I saw there's a question about that, about resources. That's one place for resources. There's also two different Slack channels, two different Slack communities, where people in a kind of a free form are sharing ideas, going back and forth. And this group has brought in a number of people, including Malia and Ajay. They've been active members of this group over the last couple of weeks. And we're looking. We have people beyond Madison as well. There's an important group in Chicago I'll talk about in a moment. If I could have the next slide, maybe. So these are some of the visualizations that have come up that are associated with our group here. The one on the top left is one that I came up with. I was looking for a good way to find to look at counties and states, and there you see a couple of counties in there. Madison's, Dane County's in there, and Milwaukee. This was from a couple of days ago. And if you had exponential growth, you'd see a straight line on those, and you see that the lines are bending over, which is what we want to see. We want to actually see them flatten out as happening in China and Korea. The top two right visualizations come from the University of Chicago group. I got in touch with that group because my brother-in-law said, you should talk to Marinia. And so Marinia leads this group. The left one is interesting because it's showing cold spots in northern Wisconsin where we have low incidence of new cases, and you see the hotspot around Detroit. So this is automatically generated across the whole United States at a county level. The one on the right is showing the actual incidence on a color scale. Now, a lot of different people are pulled into this group. At the bottom, two pictures are coming from Song Gao, who's in geography. And the one on the right is showing what's happened with social distancing. And about halfway along the picture is where the safer at home was implemented. And you see the tremendous drop off. The green curve is Waukesha County, where there's a lot of commuting. And then there's Milwaukee, and then there's Madison. You see Milwaukee and Madison have been for the last couple of weeks down at virtually nil in terms of movement. So this is based on cell phone data, which is aggregated. So its privacy is very much respected in here, but it helps get an idea about what's happening. And the curve on the left is showing what kind of activities people are doing. So the curves going down are the ones related to work. The purple curve is people in their residence, and the green curve is people going to parks. And of course, many of you know that the state parks were closed recently because there was so much activity there. If I could go to the next slide. So in addition to, so the previous slide showed looking down at a county level and up at a whole country level. These are slides showing what's happening over time. And the New York Times had a display about a week and a half ago, which was pretty exciting. It looks at a lot of different places. And some of our researchers here thought, including one of my students, Sean Kent and Steve Goldstein, thought, well, we could just adapt this to Wisconsin. So they actually put in the different records for different places in Wisconsin, and you'll see on the left curve, the horizontal axis is date, and the vertical axis is a percent change, daily change average over the last 7 days of cases. And what you want is these curves to go down. The highest curve is Milwaukee, and then one of the next highest curves, both the sort of orange curves, are Milwaukee and Madison. So you want those to go down. Then as you look on the right curve, what they're doing is plotting the same vertical axis of percent change against the proportion of cases per 1,000 people. So what you'd ideally like is a race to the bottom. You want to be down in the lower left-hand corner, and Milwaukee you see is having over 1%. And Madison is about again another orange curve down below 0.5% of cases per 1,000 people. So I have half a case per 1,000 people, so 0.05%. Let's go on to the next slide. So these are showing the data we have, and then what we'd really one of the things that we're trying to do is project forward. And Malia talked about this a little bit, and so did Ajay. Two different models. There are multiple models being explored. The models that we've talked about so far tend to be like the one in the upper left. So you have people who are susceptible, people who are infected, and people who recovered. So they're like SIR models, and you can make that more refined, as you see in the picture there. You have people going in the hospital or going to ICU or being on ventilators, and so you have this compartment model where individuals would move from place to place. And there are two types of versions of this. One is being done at the hospital with Ajay, the group Ajay is involved with, is basically modeling individuals, 500,000 people for Dane County, say. But you can also do this on an aggregate basis and get an approximation, a decent approximation. So we've been using these models to try to project what's likely to happen in the next couple of weeks. And are we are we at the surge or not? And the follow-on question is, what's happening with our supplies? How many beds do we need? When do we need them, and where are they? So there's supply chain models which build off of these compartmental models, and we're in close communication with the DHS, with the health professionals in the state about how we can couple these models together. Many of you have seen this model to the right, which is sort of the same, similar type of idea coming out of University of Washington, the IHME planning model, to look at the, this is from a couple days ago, but look at where the surge is. So this has gone around quite a bit and has, it's basically a model for the whole state. Does it make sense for Madison? Does it make sense for Milwaukee? So these are kind of questions that we're trying to ask in more detail. And one of the challenges has been, as Ajay and Malia talked about, is that we haven't had enough information, which would come from testing of large numbers of individuals, to be able to get the detailed information about the population. And we also need detailed information about what's happening in the hospitals to see if how we're meeting the capacity for the hospitals. So things are changing every day, but I think we've moved from a sprint to a marathon. That there's, as Malia was saying, we have a long way ahead of us, but there's some positive light. We're getting a better understanding each time we look at these things. And what's been really important with our research group is to bring together people. We actually meet every weekday, 12:15 to 12:45, and have a drop-in session where people ask questions and make reports. And it's been a very effective way to get people to communicate across disciplines on an ongoing basis. Thank you very much.
Thank you so much, Brian. That's a really significant effort. Last but certainly not least, we'll hear from Lennon Rodgers. Lennon's the director of the Grainger Engineering Design Innovation Lab and part of the team behind Badger Shield, which is helping to provide healthcare workers and others on the front lines of the pandemic with needed protection. Please take it away, Lennon.
Hello, thank you. Yeah, I'm here at the UW Makerspace, and I'm just here to represent the College of Engineering and discuss how we've been working with UW Health, mainly related to design and prototyping projects. I'll explain it through essentially a story. I think it's a good example of how engineering has been, with other partners, have been mobilizing a lot in the last month. So I'll first explain the request that I received from UW Health, which was to make face shields, as mentioned. I definitely want to emphasize that everything I describe is being done by a large team, much larger than just me by myself. We're all working remotely for the most part from the College of Engineering, the hospital, and many others across Madison. It's really neat to see. So this all just started about a month ago for me when I received an email from UW Health, and they asked if I could create 1,000 face shields because their supply was getting pretty low, dangerously low. If you don't know, a face shield is essentially just a piece of plastic. It's very similar to a soda bottle in thickness and material type. And it's typically worn as part of a lot of what's called PE that's used, PPE as protective equipment. So it goes on top of the N95 mask and other things. So some of you may wonder how I would have actually gotten involved in this. Full disclosure, I've never worked on anything like this in this sense, as some others have mentioned, but even more generally, I typically don't work that often on biomedical devices, though we do support a lot of biomedical student projects and research projects in the areas that I work. So this is what this slide shows, is mainly the main reason why they did contact me, and that what I do is oversee most of the design and prototyping facilities in some of the design programs and courses in the College of Engineering. So as shown in the slide, and I think it makes sense, I was contacted by UW Health because I have access to a wide range of prototyping equipment. So like many others though, kind of going back to that Monday, March 16th when I was contacted, it was really a day where schools were starting to close and there was quite a bit of uncertainty floating around. So that evening, my wife and I mainly brainstormed not about face shields, but about childcare. And since my wife is an anesthesiologist though at UW, At some point, I did mention the email that I had received, and she confirmed that it was a need and kind of gave me a first-person perspective of the situation. So after the kids were in bed that night, I headed out to Home Depot and the craft store, and really went on what I would call a prototyping shopping spree, where I just go through the aisles and throw a lot of components in that might be useful. And that night I headed to the makerspace, which is where I'm at now, and created this first prototype. It's shown on the slide there on the left. And I took it home and showed it to my wife, and she provided some useful feedback. But really, I knew, like all design projects, I needed a team. And so that next day, I reached out to Jesse Darley from Delve and Brian Ellison at Midwest Prototyping through some suggestions here at UW. And together, we created the prototype shown on the right. So what's interesting is that at that time, if you were to do some searching, which I did that first night on DIY face shields that were on the internet, most of them were being 3D printed. And I think all of us, Brian, Jesse and I, were very tempted to 3D print. We had this very specific conversation because we have access to a lot of 3D printers. I mean, you can see a lot of them behind me, and this is nothing compared to what Midwest Prototyping has. But instead, we kind of went back to some of the fundamentals of design and design process and obtained some samples from the hospital of what they currently had. We created multiple prototypes, and we received some feedback from clinicians, and we took a slightly different approach. So as you can maybe see in the picture, the face shield ended up being very simple. It was similar to what clinicians were currently using, but we tried to improve it. It could be made by pretty much anyone with a pair of scissors, but equally important, it could be made easily and mass-produced with automated machinery from factories. So it was likely the simplicity, the accessibility, and the scalability of the design that made it attractive. So while I was driving home from Midwest Prototyping, which is just a little bit outside Madison, we had just created this first pre-production prototype. But I knew right away, especially the role of a university, that we needed to get the design out to as many people as possible. And this was kind of during that sprint phase that was we were talking about earlier. And we really needed to get the design out and start to connect hospitals to manufacturers and help build up a supply chain, which actually ended up being a significant piece. So I called our operations manager at the Makerspace and asked her to create a website. And over the phone, we laid out these basic requirements for this website, which ended up being a significant piece, I think, of our contribution. So Jesse Darley from Delve created our first open source drawing with revision control, and we posted everything on the website as shown here. So that's the drawing on the left. And we started tracking different changes, and we got some feedback from the hospitals and other people that would contact us. And we updated the design and posted the latest on the website. So most of our website activities were eventually led by UW professor Justin Boutlier, who specializes in operations management for healthcare. So it was a really neat collaboration that I could talk more about if you're interested. So thanks to the article by the engineering public relations team, and later in an article in Wired magazine, the word for what is now called the Badger Shield spread quite quickly. I was contacted by Ford quite early on and others, but really the bottom line is that there have been millions of these face shields made over the last month and all over the world. It's been really neat to see. While we can't necessarily take credit for all the non-3D printed face shields, it's been super interesting, as shown on the right. There are many large companies just in the last week, like Apple shown there, Nike, Adidas. They followed a very similar path, just a few weeks shifted from the Badger Shield. And it was really neat to see, as the image shows there, Apple's CEO, Tim Cook, he walked through their design and their process, and you could tell that his intent was very similar to ours of rapid dissemination. So I'd like to now shift a little bit and just close up with some data and showing you some data that we collected from our website's intake form from the last few weeks. So this plot shows that we've had continuous growth as we've partnered with over 300 manufacturers and 250 healthcare facilities. So what's interesting to note is that the rate of increase of the supply from the manufacturers appears to be higher than the demand from the hospitals. And I could tell you a little bit more about that, and we have some more data if people are interested in the Q&A. The next slide shows that the manufacturing and hospital partners come from approximately 40 states across the country. What's remarkable, you can see there, is that it only took about 7 days for it to spread across half the country. And it really was increasing at a similar rate for both manufacturers and hospitals. And I'm sure Professor Boutlier and his team will publish papers in the future and try to explain what we've seen and how this will help us prepare for the future. He calls this pop-up supply chain or pop-up manufacturing because everything just kind of popped up quickly around the needs, which were really interesting to see. And we've been working with the Wall Street Journal over the last couple of weeks on describing this phenomenon, specifically with the Badger Shield as an example. So finally, the last slide, the face shield project is just one of many projects. And like I said, I just wanted to give you the story of how it evolved. I think it really represents a lot of other activities of mobilization in the College of Engineering. But I'd be happy, to answer any Q&As you have and try to explain the best of my knowledge about these other projects going on. So thank you very much.
Thank you so much, Lennon, and thanks to all of our panelists for your presentations, which were really great, stuck on time. So now we have about 20 minutes, just shy of, to take questions from the audience. And thank you to everybody so far who has submitted your questions. Maybe we can get started with a question about testing. Ajay, audience wanted to know, what are the barriers to testing in Wisconsin? And could you talk a little bit about the types of testing that are possible? You're muted, AJ.
Thank you. Well, when we talk about barriers for testing for this coronavirus, there are two different kinds of tests. The COVID PCR test, which has been used for over a month now, it requires a lot of ingredients to run that test. And over the last several weeks, there have been shortages of some of those ingredients, and another week, maybe another ingredient in those supplies. And so at any one given time, it sometimes has been hard to procure all the necessary things to operate testing. There was also just a general slow in scaling up that testing from the very start, because the CDC was the one to initiate the test, and only testing could be conducted at the CDC before state labs could do that. It has expanded now. UW Health is doing rapid testing, and the State Lab of Hygiene is also doing more testing. To get that even more scaled up, we need to make sure that all the supplies are available. I understand right now nasopharyngeal swabs might be in short supply at the moment. I'll say the other type of test is the antibody test, and the FDA has approved several groups around the country through emergency use authorization to approve this an entry-level antibody test, and those are being piloted in different communities. They need to be highly accurate, and if they are, they can be approved for further development and scale up, and at some point that will be very useful to determining how many people in the population are immune or have had infections in the past.
Does anybody else want to weigh in on that question? Perhaps maybe some of the other reasons that there's been some delay?
I can also just chime in and say that the criteria for testing are restrictive, as I said earlier, and restricted criteria don't create a demand for more testing. And if as a nation we can agree that testing asymptomatic cases is important, I would hope then the demand for that or the supply will follow that demand.
Great. Kristen, can you maybe explain for us the difference between antibody testing and the polymerase chain reaction style testing that I think most of us are more familiar with when we talk about testing?
Yeah, absolutely. So the RT-PCR, or the polymerase chain reaction, is actually looking for the viral genome. So you know that the person is actively infected if they have that viral genome, like the one that I was talking about earlier. An antibody test is actually looking for the host response to the virus. And you actually have antibodies sometimes for your whole life to some viruses. And definitely you'd have it for over a year for this virus. We don't know exactly how long they'll last at this point in time, but most likely at least a year. So those is a blood test, and you're actually looking for an antibody, which is the host protein that reacts against the virus. So it's a completely different type of test. Usually we're doing it when we want to know if somebody has been exposed or previously infected, or whether or not they've been vaccinated for a virus.
Great. Thank you, Kristen. Malia, you talked in your presentation a little bit about herd immunity. What percentage of the population would need to have herd immunity given how infectious this virus is?
So the answer to that is not yet known in a really specific way, but we can compare the dynamics of transmission for this virus to other viruses and make some assumptions, and come up with some pretty good guesses. And I will say, even though we don't exactly know what the threshold for herd immunity is, it's going to be above 60% of the population with immunity to the disease before we can really think about achieving herd immunity. And it's probably higher than 60. And then the other thing I want to say about herd immunity is that herd immunity is not a preventive measure in the absence of a vaccine. So the idea of letting the disease infect 60% or more percent of the population in order to provide population level protection against an outbreak is really not a prevention strategy. That just means you have 60 or 70% of your population infected over the course of time. So the herd immunity really only makes sense as a preventative measure if you have a vaccine that is providing people with that immunity through a safe avenue.
Malia, could you maybe touch upon why it takes so long to develop a vaccine? I mean, 18 months really isn't that much time, but in the context of a pandemic.
Yeah, it is a really long time in the context of a pandemic. It takes a long time for a vaccine to be developed because there are a lot of unknowns in terms of what is going to provoke an immune response in the body when you give a medicine that's intended to prevent future infection. So a vaccine is sort of like giving your body, your immune system instructions for how to recognize and deal with some future viral intrusion into your body. And there are a lot of question marks in terms of what will produce enough of an immune response, how long will it last, and whether it will be safe. And those things go through a protracted process of clinical trials before they can be released to the public and then manufactured. And so it's just a process that takes time. And in fact, 18 months would be extremely fast for a new vaccine development. The world has never seen anything quite like that before. So I'm hopeful because there are several candidates already in development, but it will be a while.
Thanks. Kristen, maybe you could talk a little bit about how coronaviruses are transferred from bats to other species to people. What are the sort of common pathways for that? As we were just talking about vaccines, does knowing the source influence vaccine development in any way?
Yeah, knowing the source doesn't really influence vaccines, except for it does let us know how quickly the virus changes. So I think that gives us some information there. Knowing the source is more important to prevent that transmission from happening again. So we, as scientists, really want to know that answer. And the other part of your question was how it's transmitted. So it's not transmitted through eating because this virus is killed by cooking very readily. It's definitely not transmitted that way. It's more in close contact with secretions that have the virus in it, respiratory secretions, potentially feces from an animal. And that's going to happen when you're in close contact. So in the live animal markets, for example, when people were in close contact, looking at the animals, they're down there on their level and actually getting exposed to any aerosol droplets or secretions and feces and things like that. So that's how we think that's being transmitted. As far as how the bats are transmitting it to another animal, there's possibility through eating, because of course the bats being eaten by a wild animal wouldn't be cooked. So that's a possibility, but again, through the fecal and other secretions.
Thanks. Ajay, could you maybe elaborate a little bit more on what contact tracing actually is? And then Malia, maybe you could help talk about how contact tracing and herd immunity are connected.
Sure. So contact tracing involves getting in contact with anybody who a confirmed case had seen during that period when they were infectious. So it usually recalls some recall, interviewing the person who's become COVID positive and asking them who they've been in contact with in the last so many days, depending on when those symptoms began or when testing began. And then to reach out to those individuals to test those contacts to see if any transmission had occurred. If somebody is positive, then you would want to make sure that they're isolated so that you can stop the further spread.
And then Malia, how might that help influence herd immunity?
So herd immunity is really a different kind of strategy for control of a disease that doesn't have, in a population of people who are essentially all immune who are essentially all susceptible. Most people have no immunity to the disease. Herd immunity is not a thing. The kind of control, but there are some other control strategies that are not herd immunity. And those are things like Ajay is talking about, the combination of contact tracing and widespread testing could tell us something, could provide an avenue for medium-term control strategy until that vaccine becomes available. And I think those have to be used in conjunction with some more conservative ongoing physical distancing measures and good hygiene practices implemented very broadly. So contact tracing and herd immunity are not really closely related to one another. They're two different control strategies.
Thank you very much. Brian, I think a lot of people seem to have questions about how long we might have to be keeping ourselves at home and staying in our homes. Your data illustrated very nicely the changes that we've made as a society. So what do we expect in terms of our safer at home orders? Is this something that we think might be extended, or might there be changes? And then for vulnerable populations, and anybody else can weigh in on this as well, but for older people or those with underlying health conditions, even if we do start resuming more of life as usual, what does that mean?
Yeah, well, let's remember, I'm a numbers guy. I'm not an epidemiologist. I'm not a public health person. So I can't speak directly to that issue. But what we are hopefully seeing, what we want to see is a leveling off of the number of cases and actually a dropping off down towards zero of the number of confirmed cases. We know that we believe that there are cases in the population that we can't detect, asymptomatic cases. So there may still be cases out there, but if we can get the numbers way down, that first of all gets us to a point where we're not putting the pressure on the hospital systems, which is one of the big risks that we're concerned about. And if we are at very small numbers of actual cases, then we can start following through with the contact tracing that Ajay was talking about. So if there's a handful, dozens, or hundreds of cases around the state, those can be followed through and identify. We have a chance of following through and identifying who contacted who and actually tracking that down. So hopefully that gets some idea about it. I think the social distancing that Malia was talking about is still an important part of it, because there's so much we don't know. We have, as Malia was saying, we have this, most of the population is susceptible, and we don't know at this point who has been infected and who might be able to transfer the disease. So until we have widespread testing and where we can make some educated guesses about that, where the social distancing is going to be an important part.
Thanks, Brian. I think we've had a couple of questions about strategies for combating COVID-19, and some of these strategies turn to maybe things that we've done in the past. So for instance, tuberculosis vaccine, BCG, has received some attention recently. Historically, early smallpox efforts were aimed at giving just very small doses of smallpox to help boost the immune system. What might be some of the different kinds of strategies under consideration for vaccine development, for developing, as we've talked about, that herd immunity as we are also social distancing? And maybe, Kristen, you can talk a little bit about some of the strategies that have been used in the past for other viruses.
Yeah, sure. There's lots of different strategies that are used. Sometimes we just completely inactivate the virus and use that whole virus. And that's a very safe way to go. But unfortunately, it doesn't usually provide a very good immune response. So that it's an easy, quick one, method, and we often use that for veterinary vaccines. Another method is to use an attenuated virus. And in that case, that's something like what we did for smallpox. That was an attenuated virus that gives a very good immune response. The problem with that, as Malia was talking about, you really have to be very careful that that is attenuated in a lot of different people, different various populations. So that's takes a lot of testing to be sure that that is going to be safe enough to use. It would likely be very effective, but the safety is always a concern. Another type that I know is in clinical trials right now is actually using a DNA molecule that expresses some of the proteins of the coronavirus, and then that stimulates the immune response. Now, that is a very safe method, but sometimes doesn't provide a very good protection. And finally, another method is using the RNA molecule itself, and then it would just have those proteins that are like that spike protein that I talked about. And those, again, sometimes are not the most effective generating an immune response, but they are quite safe. So there are several different methods that are getting some leads on. So.
Great. Malia or Ajay, if two people have, let's say that you're a couple or just you're a person who you've had COVID, are you able to get the virus again in a short period of time? And can you transmit it to somebody else even if you don't have symptoms?
I can say that it has been shown that the virus can be transmitted despite having no symptoms. How much of community transmission is driven by those asymptomatic individuals versus mild versus more moderate is not quite known, but it is known that people who have asymptomatic disease are part of the chain of transmission. It's possible that these individuals who are not being tested and are contributing to ongoing transmission they're kind of functioning as a little bit of a reservoir for the older individuals who present with more severe disease and maybe require hospitalization.
And I can add on to that if the question is about immunity to COVID-19 after you've been infected and recovered, that is really an outstanding question for science right now. And it's one of the challenges to understanding what herd immunity will look like. We don't really know yet what people's lasting immunity after having been exposed and recovered is.
Great. Thanks to everybody. I think we're going to switch over to Laura now for our closing remarks.
Thanks so much. I want to just close by thanking our tremendous panel, Kristen Bernard, Ajay Sethi, Malia Jones, Brian Yandell, and Lennon Rodgers, as well as our amazing moderator, Kelly Tyrrell, and our production team of Peter Kleppen, Craig Wild, Amy Gill, and Shauna Baranchik. And of course, I want to thank all of you for joining us and encourage you to mark your calendars for April 30th at 5 p.m. for the second part of this three-part series. Thanks so much, everyone. Be well, stay safe.